All right, we're gonna get started just because we have limited time, so we want to cover as much as we can, and then as people join, we'll admit them and obviously have the recording after that. My name is David Miller. I'm the managing partner of Rosen Dental Transitions. Going to be talking a little bit about what sellers should be doing to prepare for a sale, and also going over the current market dynamics because, not everybody views value in a dental practice the same. So depending on the type of practice you have, a certain buyer is willing to pay a premium where others may not even be willing to buy it at all. So we want to try and dispel some myths and get into some of that information today. So the first thing I want to talk about is just a brief overview of the market. So, in the private market, which is associate dentists and maybe an existing practice owner buying a second office, the demand is very strong, especially when you're within 45 minutes of a major metropolitan market. Um, People are willing to pay premiums for practices, and we'll get into like some of the criteria as to why they'd be willing to do that. Second piece is the DSO market is still active, but it's definitely less populated than it was, kind of pre-COVID and before interest rates went up. It's still active, but the buyers that are out there are more selective, and their buying criteria is a little bit more rigid than it was, say, in 2018, 19, and even through probably 2021. Along with that, I would think like seller sentiment on DSOs is not as strong as it used to be. The way I like to describe it is I feel like there were a lot of fishing stories out there. People were like, "Oh, I caught a fish this big." In reality, I sold my practice for, 10 times revenue or whatever. And that was really a pipe dream. And now that the reality of those transactions has played out, um, word is spread. And so I think, the story of like, well, my friend sold to corporate and was really unhappy has just changed the enthusiasm around everyone running towards those transactions. So, again, the market is still very strong. The myths of, people don't want to buy practices or student loan debt is keeping banks from lending just aren't accurate. So if you have a practice and you're thinking about retiring in the next year or two, it's a great time to do it still. Regardless of kind of the economic situation that we're in today. There's four real buyer types out there, but there's one common thread they all think about. Everyone cares about profit. And I'll get into a little bit about what profit means, but the biggest distinction is as the owner, it's not just everything you make at the end of the year. We have to look at what if I bought the practice and I'm not a dentist, you would work for me. You wouldn't work for free. You'd want to be paid 35% of collections, maybe minus some lab expense. So what does it cost for you to produce the dentistry that's currently being done in the practice? Now, after that is paid, what's left over is the real profit. And there's more nuance into that and like the adjustments and things we make, but that's the biggest distinction we need to think about as an owner is you can't just lump in your wages plus the profit of the business. You have to separate those two to really understand what this practice value will be. So the four different buyers out there, there's the associate doctor. A lot of our first time buyers are working in corporate today. They've decided that isn't what they want their career to be, and so they want to find their own practice to make their clinical home for the next 30 years. Second is an existing owner. They may have one office, maybe two. It's not a group practice, but they're looking for a second location. Maybe they have a really strong associate and they want to find more chair time. Um, there could be a number of reasons that they're evaluating a second option. The third is the local multi-practice owner. They usually have between 3 to 10 locations. They're not backed by private equity. They still own 100% of the business and are getting their financing through traditional banks. And the fourth person out there is the DSO private equity backed group. Those are the ones that you hear about with the roll-ups, the Aspen Dentals, the different groups that, have a, local dentist who runs the business but they have a private equity board that helps make the investment decisions when they're buying practices or looking to grow. Now, each of these have different hot buttons. So the associate doctor, they're really focused on location, a market that they know well, clinical growth potential. If you're a seller who refers out endo and doesn't do Invisalign and refers out, extractions and various things. Um, this is a, you know, they are really attracted to those type of practices. They also like stability, both within the staff and the patient base. Um, if you're the existing owner, that 1 to 2 location that may be looking for another one, a big thing with them is the transition plan. How's the clinical responsibility going to be passed off? The second thing we found is the growth alignment and the philosophy fit. So, how similar is your practice to theirs? Is it going to be a massive change? You're a Medicare, Medicaid practice that's high volume and they're a fee for service office that takes extra time with patients. That's obviously not a philosophy fit. So they're really in tune with how does the front desk run? Who makes, is there an office manager? How do you schedule? What insurances do you accept? Those are big pieces for them as they think about adding a second location. The multi-practice owner, that starts to lean towards what's your transition plan? Will you be willing to stick around for at least a year, maybe two? They have more flexibility than DSOs, but they want some continuity from the seller after the sale. Proximity to their other locations. So if they have 5 to 10 offices, does your practice fit a geographic market that will help them connect practices and create more market saturation where they can leverage staff, right? Like if I have a doctor in one office, could they give me 2 days or could specialists travel to all of our offices? Um, the third is profit potential. How many specialties you refer out. Usually, if they are 5+ locations, they may have specialists that travel to all their offices. And so they're looking for ways to maximize those specialists that are within their umbrella of practices. The fourth one, which is the DSO PE backed, the conversation starts and ends with EBITDA. They have some minimum requirements in terms of size. They prefer 2+ doctors. They prefer 6+ chairs. They prefer revenue over 2 million. Um, they like to stay away from Mass Health, Medicaid, Medicare. Um, but at the end of the day, they care about profit, which to them is ROI. The higher that profit is, the more they're willing to pay. And then they're going to kind of check the boxes to make sure there's not some deal killer from a philosophy or criteria standpoint that would keep them from moving forward. So, again, 4 buyers in the market, all different hot buttons. But at the end of the day, profit is what starts the conversation and will set the range of value for what your practice might sell. Where you end up on that range is going to depend on the buyer and the fit and the motivation. So, the obvious question is like, well, when do buyers pay above? The associate doctors, where we have seen them pay above value, is when you are in a highly desirable market geographically, and it's a one doctor practice with growth potential. So the practice that's doing $1 million and it's a GP restorative office, the seller refers out, they're doing just crowns and fillings, they're referring virtually everything out. And maybe there's 4 chairs equipped, but there's a fifth room plumbed. So there's a pathway for growth without major construction, being turnkey in terms of not having to sink a ton of money into equipment and renovating. We'll see buyers that will pay premiums above the asking price, and we can get bidding wars in those situations where, that $1 million practice, a corporate buyer won't even be interested in buying it. Um, and an existing owner or multi-practice, they may be open to it, but they're not as enthusiastic about it because, they're still going to have to pay someone to work there. The associate doctor is looking at this as I can do all the dentistry here. I'm going to keep all the cash flow from the business. And, I love to do endo. I do Invisalign. The seller refers those out. There are very clear paths to growing this office. So that's where we see the associate doctors pay a premium. The existing practice owner who has one location is getting their second. The big hot buttons for them are a stable transition with philosophy alignment. When they walk into the practice and it feels like their office and they talk to you about how you schedule and what the days look like and how the staff lays out in terms of assistants and hygienists and front desks, what insurances you're in network with, how it looks and feels from a just like waiting room, equipment, technology that's in the office, that type of practice that is, obviously reasonably close to their other office, is something they're going to pay extra for. The multi-practice owner who's not DSO backed, but has maybe 5 to 10 locations, they're really looking for geographic fit. Where do they have holes in the local market that this practice can fit into? And again, we talk about leveraging existing staff, oversight of the office by using other employees in other locations, and the ability to refer patients. We could have a practice that's really, really busy. And if this one is the next town over and we're booked out at this location and getting new patients, we could send them to the next town to see that office. The other piece is the referred out specialties. Again, usually if they're up to 10 offices or 5 to 10, they probably have an endo, a perio, an oral surgeon, maybe even a traveling orthodontist that works in their other locations. So the more days they can fill with that specialist, the more leverage they're getting out of that employee. And it's an easy path for growth for them. So that's the hot button for that local multi-practice. We've also found with this group, it's not universal, but if the real estate's for sale, that's great because these doctors usually have excess cash flow they're looking to invest, and real estate is a great vehicle as it relates to the practice for them to build equity outside of just the business. So the fourth group, the DSO or private equity group, it's when the EBITDA gets above 850, but the massive purchase prices are when it's over 1 million. So these are practices that are typically collecting 4.5 million annually. They have potential to have EBITDA over $1 million. Um, so if you're in that large practice, then the multiples and the prices they're willing to pay for those offices start to change the conversation about financial benefit of selling to them. So um, that's a really, really important piece. The other thing is a turnkey facility. Listen, the perfect deal for corporate is they can buy your practice and they don't have to worry about it. It's got good systems in place. It's newer equipment, so they're not worried about replacing chairs and bringing in technology that doesn't exist. Um, that allows them to recruit dentists, right? That's another piece for them. If you're in a market where it's easy to recruit dentists to work, that makes it more appealing for them to buy because that's the one thing they can't do. So if they know there's always an active pool, that's why here in the New England market near West Hartford, where you have UConn and that dental school, getting down in Fairfield County of Connecticut, where you have NYU and a lot of people want to live or will commute from the city. That's a very desirable market. In the Boston metro area, obviously there's Tufts and BU and Harvard and all the different dental and specialty programs, Portland, Maine, areas where, again, there's the ability to recruit dentists to work and help them replace quickly if someone were to quit or leave. So again, it depends on, this is where you got to think, all right? If I have a one doctor practice with 5 chairs, you may be thinking, oh, I want to sell to corporate because I want to maximize my sale price. They're not going to pay a premium for your practice. They might not even want it. And so your better bet is to sell to an associate, which may sound counterintuitive, but that person is willing to pay a premium. They have access to capital through dental specific lenders, and they will be more motivated to pay above your asking price or above the value because it can be their long-term clinical home. So that can be counterintuitive for some people, but we think it's important to remember that. And speaking of that associate doctor buyer, what they're looking for, again, location, it's within that kind of commutable market, or maybe it's a market they're very familiar with. They grew up there, maybe they've associated in that area, but they know that demographic and patient pool. The clinical growth potential is a big piece for them. They're always going to ask us what's being referred out, what are they doing in-house? And a deterrent can be procedures that they can't do. So if you place implants, any doctor who can't place implants is not going to be in favor of your practice because they have revenue and profit to replace and they don't have the clinical ability to do it. Um, if you are a, fee for service, highly cosmetic doctor, that's a very specific skill set. So that buyer needs to be comfortable doing that. They can't come from a Medicaid, Medicare where it's high volume. There's not a lot of financial consideration around what's being done because it's all being covered by the state. They need to have worked in that type of fee for service, high touch, high service environment. The other thing they're looking for is operational stability, and that comes in two factors. One is the staff. How tenured is your staff? And some people will be like, oh, people have been with me for 40 years. That's great, but it also can signal risks to the buyer because the buyer will fear that upon the sale, those staff members will retire with you, right? So you really want a balance of, tenure, but not being too old. I know that's not really in your control, but just want to, give you a heads up on what buyers get nervous about. So again, when you have that single doctor practice with high upside potential, a loyal patient base because you're in a community where it's not all apartments, there's a lot of homeowners and families, and it's not just a business district, that leads to a strong, loyal patient base with good hygiene retention. And the other thing is clean financials with no major deferred costs, Hey, all my operatories are 20 years old. I've never replaced any of the chairs. Well, that's great for you because you haven't had to incur that expense, but the buyers will look at that and say, all right, I've got to put all new chairs in here. Or if I don't, they're going to break soon. And so that's a something that's going to um, make buyers want to maybe offer below asking or be a little bit more conservative because they're anticipating a future expense that isn't part of the deal. Shifting to the opposite end of the spectrum, the DSO PE backed buyer. EBITDA, and I know that's a fancy word. At the end of the day, they're talking about profit. They're going to need you to stick around. All groups want you for 5 years. Sometimes you can negotiate that down to 3, but that can impact their willingness to pay a premium for you. So they need you to stick around post sale, and um, their price is going to be a multiple of your profit. So if you're sticking around, you're going to have a compensation agreement. What do they have to pay you to do the dentistry that you're doing today and maintain that production level for 5 years? And after they pay you, what's left? If that number is 500,000, they're going to pay more than if that number is 250,000. And there's a math problem that comes into this where there's not really a financial benefit of selling to corporate. It's more a function of what are you looking for. You want to sell, but you'd love to continue work as an associate. Okay, corporate might be a better fit just because they are always going to need a dentist. So you're always going to have a place to work as long as you're happy and you want to stay there. When else will they pay? We talked about recruiting and that, the fact that the one thing they can't do is dentistry. So if you fulfill your 5 years and you're ready to retire, they need to bring dentists in. And those dentists aren't going to have the same loyalty and commitment because they're not being paid a retention bonus or they don't have equity in the business like you do. So they want to make sure that if that dentist lasts 2 or 3 years, they can find another dentist. So being near a dental school or a city that's desirable for people to live is really important in recruiting talent for them. The last is the facility. The more operatories, the better. And the more modern the technology, so they don't have to incur the capital expense of, you know, bringing in scanners, bringing in a CBCT, doing those different things that, really are going to create a clinical environment that is going to attract top talent and retain them. So that's going to be a big piece of it as well. Um, the last piece I would say is insurance participation. If you do participate in Medicare, Medicaid, there's some groups who just don't touch that. If you accept those insurances and it's more than 15% of your collections, they just won't buy your office. It doesn't fit their model. They're not comfortable with it. So that's a big piece too. There are groups that are interested in that space, but you just need to understand what you're getting into there. So again, long story short, with the DSO private equity backed is higher profit, um, highly desirable geographic location for recruiting dentists and turnkey facility, and the seller willing to stay for 5 years. So if we can start to think about who the ideal buyer will be based on your type of practice, how do you plan your exit 3 to 5 years out? Honestly, I think it should be further than 3 to 5 years out. You want to understand your value and analyze the drivers of your value and the constraints. And my philosophy is if you're going to own your practice for 15 more years, wouldn't you love to make it more profitable so that the next 15 more years you can make more profit and have less stress? So you really want to get this done, I think, as soon as possible, is like have an analysis of your practice done. Because then that allows you time to fix the issues. If you came and said, all right, my practice is worth $1 million. I thought it was going to be worth 1.5 million. I want to fix it and make it worth 1.5 million, and I'm going to have to do these things in my office. You got to assume it's going to take 1 to 2 years to implement the change, and then it's going to take 1 to 2 years to flow onto your financial statement. And then the financial statement and tax return is what is going to make a buyer pay more and allow a bank to finance more. So if you want to retire in 6 months and you get an appraisal or evaluation done and your practice isn't worth what you thought, you don't have time to correct it, right? It's not like, we can certainly show buyers that potential, which may get them more excited about the growth, but it's like paying for a house, putting a house on the market and saying, "Hey, we're asking 100,000 more than the value because think about how great this kitchen could be after you renovate it." Well, it's like I'm the one who's going to have to renovate it and spend the money and the time and energy and the headache of going through that transition and change. Why would I pay for that if I'm going to have to be the one to do the work? So that's why you need to get this process started early so you can implement change and have it reflect the value that you put the practice on the market for. The last piece is, position it to sell. It's going to be a confidential process, but you want to go to the market with a very clear prospective buyer that you're targeting. Because when you can communicate a clear vision to how this transition can be successful, that can be very compelling for the group. If you just kind of shotgun it out and say, "Hey, we'll take a DSO, we'll take an individual, we'll look at a multi-practice owner," it's not the worst thing in the world, but your likelihood of creating a competitive environment that could lead to a bidding war, that could lead to not only maximizing the price, but allowing you to pick the buyer you're most comfortable with. We always feel like we're doing our best job as a broker if we can go to the seller and say, "Listen, we have three offers at very similar amounts. What buyer do you like the best? Who do you think your staff is going to love? Who do you think your patients are going to resonate with? Who did you feel comfortable with based on their clinical background?" That's the position you want to be in where you can pick the buyer and you don't feel like you're just offering it to someone. So, planning early is just going to be helpful for you in the long run. There's a couple symptoms we see that hurt value, and it's different for every office. But one that's right now, especially with the staffing challenges and shortages in hygiene, is too many insurances. We don't think everyone should be fee for service, but if you're a one doctor practice, it's very rare that I think there's a point where you should be in network with more than one or two insurances. Being a network with 5+ practices as a solo provider, it's very hard to achieve profit margins that allow you to practice the dentistry you want to practice, but also achieve the sale price you want to get. A lot of times we see people that have low profit margins and their staff expenses are high. It's because they're seeing a lot of patients, but their reimbursement rates are low because everyone's in network with an insurance, and some of those insurances aren't paying market rates. So you have to look at those insurances and understand where can you cut and still have a strong, profitable practice. Revenue cycle issues, it's a fancy word for accounts receivable. We see people that just have sloppy AR management, and that's usually disguised by patient credits. So, patient credits happen for three reasons. Could be work in progress. Those are good patient credits, deposits for future work. A lot of times there's insurance overpayment. You collect a copay and the insurance covers more than you thought. That money never gets refunded to the patient, so a balance of $13 sits on there for years. The last is posting errors. That's the worst because they're not even real credits. Could be a typo by a front desk person. It could be someone who doesn't understand necessarily how to apply payments, especially in families. They apply it to the account instead of the patient. There's a lot of things that could cause this, but you need to have someone look at how are patients billed? When money comes in, how is it applied to the accounts? And if there's a shortage, what's the process for collecting that money? Also, how are copays calculated and when and how are they collected? Those are the biggest things we see that are not clinical. You don't have to go to CE. You don't have to learn how to do a new procedure and buy new equipment. You just have to train your staff and implement some systems. Third is high staff overhead. Again, everyone knows that hygiene fees are increasing, or hygienists' wages are increasing. And everyone in general has had to give raises over the last 3 to 5 years. And if that is paired, like what I tell people over the last 24 months, If your revenue is flat, your value went down because everyone's overhead went up, especially in the staff area. So, revenue and collections have to keep pace with the increasing overhead you've had to incur over the last 24 months. And a good analysis should help you uncover where those opportunities are. The last one is outdated fee schedules. It seems silly, but I'm shocked at how many people, you don't have to be at the top of the market, but you want to at least be in the 80th percentile for what people are charging in your area. And the response is, well, I only get what the insurance pays me anyway, so who cares? Most practices, if you're a network with two insurances, 30% of their patient base is out of network or they're cash patients. And so adjusting your fee schedule can drop 20, 30 grand to your bottom line. And that is a meaningful number when it comes to determining value and, just your overall collections on an annual basis. So the last piece in before we wrap up is know your value before you list. And I think there's a difference between an appraisal and an analysis. The appraisal gives you a number. The analysis should explain why that number is the number. An appraisal could be a snapshot in time where an analysis should show a roadmap for improvement and what things you could do and maybe in what order to help, grow the practice collections and profitability. An appraisal could be a buyer facing document. It's pretty template oriented. It's usually a lot of pages with a lot of, I don't know, fancy jargon. But like an analysis is a tool for the seller. This is something that should empower you to make decisions about when you want to sell, who you want to sell to, and how you want to run your practice leading up to the sale to maximize that transition. Um, Again, these appraisals could be templated standard deliverables, and a full analysis can give you a clear strategic advantage in how you're going to move forward with this practice. So, again, what the analysis should reveal is what buyer type's the best fit, what's driving value, clear steps to help grow it, and a realistic timeline for how your practice could sell. So, again, 3 to 5 years at a minimum. Earlier the better. If you're 10 years out, it's a great time to get a valuation done on your practice. That's a big part of what we do. We do close to 75, we call them simulated sales a year, where we run sellers' practices through the process of if we were to put this on the market, what would we be worried about? Who would we be targeting? What would we expect it to sell to? Who's the ideal buyer? And going from there. So thank you all for joining. If you have questions, you can always email. I want to, we said we'll do it for 30 minutes, so we want to keep it at that time. But at the end of the day, the right buyer is out there. Understand who the ideal buyer type is, get a full practice analysis done, not just an appraisal, and then address the symptoms before you go to the market, right? Part of finding the right buyer and getting the value you deserve is having a clear plan that's going to create a more clear, consistent outcome. So thank you, everyone. Have a great evening. Again, this is Dave Miller from Rosen Dental Transitions. We hope you enjoyed the presentation, and we will be around to help with any of your questions or needs regarding your practice sale. Take care.